بسم الله الرحمن الرحيم. احنا قدامنا 5 دقايق هنبتدي شرح. أول حاجة نقول بسم الله الرحمن الرحيم، نبدأ مؤتمرنا ال 14 أو نستمر في مؤتمرنا رقم 14 السنوي، ونشكر الزملاء الأفاضل اللي قدموا الحالات الجميلة. في شوية بس ملحوظات عايز أقولها، لو سمحتوا نقفل التليفون الموبايل عشان ما يرنش واحنا بنشتغل. تاني حاجة، الكورس اللي احنا بنديه دلوقتي الريفيو كورس is circulated by the EGYSIR Global Engagement Committee. فالofficial language is English. فأرجو أي تساؤل أو أسئلة مع المحاضرين أو المتكلمين تكون باللغة الإنجليزية. والحاجة الثالثة مش خاصة بالريفيو كورس، خاصة بكل الأنشطة. أرجو الالتزام بالمواعيد عشان ما نحصلش أي لخبطة فيها. يعني اللي بيقدم محاضرة أو الأسئلة لازم تقف في الميعاد بتاع النشاط التالي على طول. وأنا بشكركم جدا على حضوركم واهتمام بالحضور المبكر، وإن شاء الله يعني الموضوع مش هيبقى ناجح من غير مشاركتكم كلكم. يعني شوية ملحوظات بسيطة حبيت أقولها. إحنا فاضل دقايق ونبدأ النشاط. هل دكتور أندرياس ريكا على اللاين ولا لسه؟ أنا شايفه بس مش عارف هو سمعنا ولا لا. I will start presenting Dr. Reka. Okay. We start our review course on the sideline of our 14th annual meeting of the Egyptian Society of. Our review course today is circulated and addressed by the American College of Rheumatology Global Engagement Committee, and we are honored by the contribution of international experts of the best to present us with the best updates and coverage of important topics for us as immunologists and rheumatologists. We'll start our meeting today with Dr. Andreas Recke. Let me introduce him first. From Germany, Dr. Recke is Associate Professor and Senior Physician for Allergology, Dermatology, and Venereology. He finished his medical studies in the University of Kiel in Germany, where he had his doctor's license in the year 2000. Dr. Recke presented his doctoral degree in the Department of Dermatology and Allergology and Venereology from the University of Lübeck. And then he had so many publications with a total number of 108. He has 3,320 citations from the Google Scholar. He has an H index of 33 and the cumulative impact factor of 49,597 cumulative impact factor. He had many awards and prizes from the research grant by the German Dermatological Society and from the Euroimmune Transfer Award by Euroimmune and from the European Academy of Allergy and Clinical Immunology. And then he is a member of innumerable number of societies and research groups covering all aspects of his interest. Dr. Recke, we welcome you to present your topic in our annual meeting review course. You are most welcome and we are honored by your presence.
Thank you very much. The honor is on my side too. I hope you hear me well.
Yes, I'm doing well. I hope you too.
I need
is
to
the connection
share my
okay?
screen.
Yes, please.
It's
Dr. Recke will present us with his update on a new perspective for angioedema. And by the way, I forgot to say that Dr. Recke is an expert statistician as well, as I knew from his colleagues.
Thank you. Maybe this was that Saleh Ibrahim actually told you about. So thank you for your kind introduction. So I'm going to talk about angioedema, a new perspective, and I will walk you through the current classifications and treatment strategies. I hope you can see my presentation screen. Here are my disclosures. I'm organizing here an annual conference for allergology, so we had a lot of sponsors, and this is actually the list that's accumulating. Here's just for overview where I'm talking to you from. Here in the north, here is Lübeck, and this is a flight line of about 6 hours to reach Cairo, although the time zone is only 1 hour difference. Here, this is actually an overview of Lübeck. From the top, it's a kind of island between 2 rivers, and it's famous for its 7 towers. You can just count here, there are sometimes double towers. These are the 7 towers of Lübeck. And here just some aspects of where I'm living. And here is actually the place I am now sitting and talking to you from now. So the outline of this talk comprises the medical history of angioedema, the current DANCE classification from 2024, some diagnostic approaches we're using here, and therapeutic approaches, and depending on the time that's left, I'm gonna also present some fancy cases. Angioedema is a disease which occurs in humans and animals as well, and it's characterized by swellings, often in the face, but it's also found on extremities, and I will come to that later, also abdominal organs. The original description was, people called it the Quincke edema, was by here Mr. Quincke in 1886, but doing more research on that, there was an earlier description by this guy here, Marcello Donati. The term edema comes from the Greek word oedema, which describes just swelling of organs. And Heinrich Irenaeus Quincke described this first as an acute circumscript and edema, although there was somewhere else in Chicago. Benester of Chicago said it's his first description. The name itself was from Felix Mendel in 1902. It was not Quincke himself who actually named it. The disease or the description, the first description may be found here from Marcello Donati. You can actually download the whole manuscript, De Medica Historia from Marcello Donato, online. It's all in Latin. I tried to actually follow this citation, but I was not able to really locate that and the words that's behind it. But if you like, you can try it. My Latin proficiency was not well enough to do that. There are some other guys who described that, especially John Milton should be mentioned here, who described a little bit earlier a giant urticaria. The first naming of hereditary angioedema was from William Osler in 1888, who described a family who had all angioneurotic edema. The term angioneurotic is actually obsolete by now, but earlier people thought it has some kind of psychological background. In 1960 around, the first indication that it's an enzyme inhibitor deficiency that was associated with kallikrein came up, and in 1963, the absence of serum inhibitor of C1 esterase was described as the cause of hereditary angioedema. Then it needed some time, and it was Konrad Borg who first described a factor 12 deficiency responsible for occurrence of hereditary angioedema with normal C1 inhibitor. A lot of other mutations are known by now. And this is the new DANCE classification where we are aiming at. It has been developed because people wanted to harmonize the terming or the naming of angioedema and to somehow incorporate the new developments of treatments and the new the knowledge about pathogenic ways. I will walk through this, and I start with the AEMC. It's the mast cell related angioedema, and we have actually 2 types. One is actually a manifestation of what a disease we call chronic spontaneous urticaria, which is actually an autoallergy or an autoimmune disease. It is typically triggered sometimes by pseudoallergens or infections, or sometimes by non-steroidal drugs. And this is because the mast cells contain a receptor which actually primes their reaction, meaning that they may trigger attacks by non-IgE mediated mechanisms, but the IgE is part of the whole reaction. I will come to that a little later. Antihistamines are often effective, but in cases where it is not the case that they are effective, we start with omalizumab, and this is typically then treating sufficiently about more than 90% of people. The other variant is actually a manifestation of anaphylaxis. It's called AE-ANA. It's less common, and you always find a trigger, an IgE reaction against a certain trigger. You always find wheals in patients with this type, but this is not completely true, not always. About 1/3 have this combination, and sometimes you even find this angioedema without wheals as manifestation of a urticaria. We still call it urticaria. Why this is, we don't know. Animals have similar patterns. I already showed you this dog, but you can also find wheals in horses. And the disease is typically an autoimmune or autoallergic disease. The type 1 autoimmunity or autoallergic disease, there you find IgE against an autoantigen. It is presumed that it's mostly thyreoperoxidase, the antigen you have in Hashimoto disease, but you have IgE autoantibodies. We make a surrogate measurement. We measure IgG anti-TPO to make the diagnosis. And type 2 autoimmunity is something we have with, we have antibodies that aim at the receptor mast cells, the IgE receptor, and is able to bridge it to make a signal, or you have anti-IgE antibodies that are bridging these receptors too. This leads to the type 2b autoimmune urticaria. And here is the current concept. So you have these type 1, type 2b autoimmune reactions and different modulators, meaning stress, food, pseudoallergens, or drugs, sometimes even aiming at the complement system or infections that will trigger attacks. This model combines all the observations we have in our daily routine. Some people have a pseudoallergen intolerance, some don't. And here are some allergens that are typically associated with anaphylaxis manifestation, angioedema. For example, insect venom is a very, very common cause for that. The rule of thumb to distinguish these two diseases is that you have two organ involved, especially when you see low blood pressure or gastrointestinal symptoms or respiratory difficulties, you have to think about anaphylaxis. Now coming to my favorite topic, which is hereditary angioedema, and this is now separated into actually 3 groups. I start with the hereditary C1 inhibitor deficiency. C1 inhibitor is a very special serine protease inhibitor, and you know about more than 800 mutations. And when I compare all the patients I have in my place, I did not upload all the mutations I have. They are still not found in the CleanVar database. Every family seems to have its own mutation, but you find de novo mutations in 25% of cases. And all of these mutations are located at different places, and they lead to unlimited production of bradykinin because every mutation is able to lead to a autosomal, the dominant positive effect of a C1 inhibitor deficiency. So you always find autosomal dominance because one allele is diseased, and it also causes the healthy allele to become ineffective or disturbed. And most important, you cannot treat it with omalizumab, antihistamines, or corticosteroids. Here are typical symptoms, and they involve the laryngeal edema, which may be life-threatening, especially in this case of bradykinin-induced angioedema. When you compare it with ANA-URT, this is normally not that critical, but here in this type of angioedema it is. And very typical is the gastrointestinal edema. People have diarrhea, vomiting, very, very colicky, painful abdominal swellings. And it looks like this. This is here during an acute abdominal attack. And you might imagine that it's really, really painful. And very typically, you find people who have some kind of surgery scars because they may have presented as acute abdomen in the emergency rooms and then get their appendix removed or whatever. So which is typically then not inflamed. What you typically have to do if you have patients like this, you need to treat them specifically with C1 inhibitor to somehow get the attack ceased. Another variant is the acquired C1 inhibitor deficiency. And this is typically associated with lymphoma or myeloproliferative diseases. Sometimes you might find autoantibodies against C1 inhibitor, but most of our patients with that, we have about 4 in our center, have a kind of hematologic disease. And typically you find C1q reduced. And even not only that, also C3. In hereditary angioedema or hereditary C1 inhibitor, it's mostly C4, which is reduced, but not C1q and not C3. It might precede the hematologic disease, and it might be possible to treat it by treating the hematologic disease. But as I said, typically anti-allergic medication is not effective. And the so-called angioedema with normal C1 inhibitor, we have here 3 variants. One is here the coagulation factor 12 I already mentioned, but there is also a plasminogen variant and a high molecular weight kininogen variant that is associated with it. You can only detect them using genetics, but in many cases you might find no mutations because, as I said, every family has its own mutations, and there are a lot of other factors in the pathways that might be also affected. And these are those that have been identified in some families. But when you have a single person, it might become impossible to make such a diagnosis for a certain gene. I will always recommend to do genetics, but we're still in the beginning. Then there is another clause called IE with vascular endothelium changes. Here are some variants of hereditary angioedema with normal C1 inhibitors, meaning genetic changes in the angiopoietin 1, myofilin, and heparansulfate 3O sulfotransferase 6, also known as HSST-HAE. There are no treatments available for that condition. Even the disease, the specific treatments for hereditary angioedema we have are maybe not effective. And sometimes you see changes in the nail fold capillaries. There's also one disease called systemic capillary leak syndrome, which is life-threatening disease, which is also categorized into this type. There's another class, it's called drug-induced angioedema. I personally like to mention that if you have these drugs that influence mainly the bradykinin pathway, they are also able to elicit reactions in hereditary angioedema. They can do it alone without hereditary angioedema, but sometimes patients with a genetic change might become manifest when they have one of these drugs, most specifically ICE inhibitors. There is another trigger, which is the NSAID, like aspirin intolerance, that can trigger the so-called AE or the urticaria variant. But this is something else. This all has been debated, this category, but in the end, the people made a vote and said we use this category to describe this AE with NSAID under this class. And there are some unknown mechanisms, which is actually a residual category, and it comprises variants of hereditary angioedema with unknown mutations. Eosinophilic angioedema called the Gleich syndrome, where you have a hypereosinophilic syndrome, and they might present with angioedema, a completely different type of treatment. And sometimes we have patients, single patients with no family history and de novo mutations, or maybe de novo mutations because they haven't been detected. You cannot prove they are. They might be an HAE, but they will fall into this residual category, AE unknown. There are some issues with the nomenclature, so the ICD classification does not include this new categorization, and the wording of angioedema drugs, especially in Germany, have different wordings. We have the advantage in Germany that if there are some conditions fulfilled, like the disease is life-threatening or very burdensome, and if there's no approved treatment that works, and if the intended off-label treatment has a realistic chance to be effective, we can get reimbursement often after proposal to the health insurance. So how do we make the diagnosis? Here is an overview of the German guidelines, or the European guidelines. You have Wheels or angioedema, then you look here, when you have angioedema, you have ACE inhibitor treatment. Does it improve when you stop it? If yes, then you have this drug-induced angioedema or ACE inhibitor-induced angioedema. If it does not stop, and if you still think it could be something hereditary, you check a C1 inhibitor, you might come up to this disease, the hereditary angioedema or the acquired angioedema. Otherwise, you might have this combination of urticaria behind that. And then you have either the chronic inducible urticaria with angioedema or chronic spontaneous. I typically see angioedema with chronic spontaneous variants. There are other things here coming with wheels that might be an anti-inflammatory disease or urticarial vasculitis, but I won't focus on that. I like to do some screenings, especially the guideline says you don't need to do too much, but when we have angioedema, we typically check for C1 esterase inhibitor function and concentration on C4. You might check for thyroid antibodies. We do tryptase. Sometimes you see people who have possibly hereditary alpha tryptasemia. If you find the tryptase above 8, you look for total IgE and inflammatory parameter. This is normally sufficient. I personally like to do some screenings for autoimmune diseases like rheumatoid arthritis or collagenoses or pernicious anemia. And in case of potential autoinflammatory disease, I personally look for the paraproteinemia or calprotectin, some other systematic or systemic inflammatory parameters. Whenever you see one of these red flags, you have to think about bradykinin-mediated angioedema. The most important things are here family history, then long staying disease and set during childhood or adolescence, and the failure to respond to typically anti-allergic diseases. And if there is an absence of wheals, sometimes you have prodromal symptoms, and if you have gastrointestinal attacks and often also genital edema, just think for bradykinin-mediated angioedema. You can try to make a diagnosis using theranostics, just that you take certain drugs and systematically evaluate which ones are responding, which ones are not. If the disease, if the angioedema reacts to antihistamines or omalizumab, you can be sure this is a kind of urticaria variant. If it doesn't, it may be a bradykinin-induced angioedema. If you do it very systematically, it might be possible that you can treat it using kallikrein inhibitors that are specifically meant for hereditary angioedema. If it improves at one of these drugs, it may be very likely a bradykinin-induced angioedema. Although I observed angioedema with mast cell-related angioedema that might react positively on icatibant. So I'm not completely sure whether there is bradykinin exclusively involved in this bradykinin-induced angioedema, or whether it might be some kind of secondary mediator that leads to angioedema in case of urticaria. I personally like to use patient-reported outcome measures. They give you some quantitative information where we typically have only subjective information when we take the patient's history. And I'm always very impressed when I see that, and because the patients are sitting there normally healthy without attacks, but then they may fill out these prompts, and then you have an angioedema-related quality of life issue of say 70%, which is very typical for this A ward, then you ask yourselves, oh, why didn't I hear that? So I personally like to recommend this AE quality of life and the AECT. Here's how it looks like, just 4 questions. The patients just need to answer that, and you give 0 to 4 points. And if you have in some less than 10 points, then you know that your treatment is not sufficient. When you have 16 points, then you can start reducing the current treatment. But how do you do treatment? When you have the classical mast cell eventful angioedema, or what you will often have in case of patients with angioedema, then just start with a 2nd generation antihistaminic drug. Just increase the dose if it's not sufficient up to 4 times. If this does not help after some observation time, here they say 2 to 4 weeks, then you start with omalizumab. You can even increase the dose, shorten the interval, and it is possible to use it as an add-on to use cyclosporine. This sometimes is able to break the cycle of recidivating urticaria and angioedema. Here is an overview of the receptors and target structures that might be addressed. You have the B cells, the T cells that are involved, and the mast cells, of course. And some of these drugs, like the c-KIT inhibitors, barzolvolimab, prequelimab, are able to deplete all mast cells. So you remove all mast cells from the body, and this typically lasts for 3 months. Then they will have been regenerated, and the patients remain symptom-free for that time. This dupilumab is something that's coming up, going more into a different direction here, especially in the production of IgE, and you have maybe an even similarly strong effect like these IgE receptor or free IgE binding antibodies. Then you have the TSLP receptor inhibitors. EP262 is for this specific mast cell receptor MGPRX2, which triggers pseudoallergic reactions. Here is an overview of the clinical trials that are now running, and most of the drugs that are coming now are aiming at IgE. This is more those biosimilars that are for this omalizumab now underway. Then the c-KIT inhibitors. BTK became very important. Remibrutinib will be one of the next drugs that will be available for urticaria and of course then for these AE URT variants. Some other target structures like JAK and JAK1 or this MRGPRX2 are also underway. Looking for that. For the AEBK, you have to think about several therapeutic concepts. One is you go for attacks only. This is maybe related to the fact that substitution of C1 inhibitor was the first treatment, and this was not something that was available in large amounts. And second thing is the long-term prophylaxis. This is now running more regularly since 2019. Starting with lanadelumab. It was available for some time to have this treatment with C1 inhibitor since 2006 IV, but people typically do short-term prophylaxis. Actually, it's like an on-demand treatment before something happens. And now we need to treat breakthrough attacks. For short-term prophylaxis and acute treatment and for breakthrough attacks, we have now 4 substances available. It's one, this Barinet P and the Cinryze are both human C1 inhibitor concentrations. Then the recombinant Ruconest, all for attacks, and icatibant is the bradykinin inhibitor, which is given subcutaneously and also available for on-demand treatment. The long-term prophylaxis, since 2006, we have Cinryze IV, but then in 2019, since then we started with Takhzyro, which is a subcutaneously given injection and antibody against kallikrein, activated kallikrein, which is very, very effective and given every 2 or every 4 weeks. Similarly, you can have The subcutaneous C1 inhibitor is also berinat-P. You have to give it every 4 days. Orladeyo is a drug also known as berotralstat, which is given orally once a day, working very nicely. And cyclopropone tranexamic acid is used in some cases. We do not do that typically here. Some people like to have it, but it has a variable efficiency. Attenuated androgens, I do not list them here because they're second line and they're not available here in Germany. It's something that has a lot of side effects and actually has problems with evidence. Here are the approaches that are now available for bradykinin-induced angioedema. You have the target structure, so factor 12A, kallikrein, C1 inhibitor, and bradykinin B2 receptors. And this is the overview of studies that are now going on. And you see here that there are a lot of drugs aiming at kallikrein. And what I like to be most important is that there are some drugs, especially for genetic therapy. And here, this is a very special thing about hereditary angioedema because it's a disease you might be able to cure with hepatic targeting of gene therapy. This here is the donidalorsen, which will be available soon. This is an antisense oligo which inactivates prekallikrein. And the similar thing is with siRNA, the ADX324, which is meant to inactivate prekallikrein 2. Then there is an approach that uses adeno-associated viruses to put a healthy C1 inhibitor gene into the liver. The only issue here is that this study has been stopped because of safety issues. What's now running in phase 3 is a CRISPR-Cas editing of the prekallikrein gene, which leads to a long-lasting suppression of the prekallikrein gene. You might ask, what does it do when you suppress it for long term? Actually, there are some knockout humans known. It's called Fletcher factor deficiency, and they actually do not have symptoms. No increased bleeding, no other problems. The only thing you see is that the partial thromboplastin time is increased. That's all. So for other angioedema types, there's not much specific known. In case of the Gleich syndrome, you have to treat specifically the hypereosinophilic syndrome. I think we have some time for fancy cases. The first one is a patient with a chronic lymphatic leukemia, has 1 to 2 times per month heavy swelling, and typically anti-allergic drugs did not work. Here you see, the face, the hands during attacks, and here you see the lab values. And you see C1q is induced, and C1 esterase inhibitor is also reduced to non-measurable levels. So now you can make the diagnosis, which is then the bradykinin-mediated angioedema due to acquired C1 esterase inhibitor deficiency. You can try a lot of things. Nothing is in label. Finally, what we did was to give the patients an emergency treatment with C1 inhibitor or icatibant. And then we started with lanadelumab after a proposal to the health insurance. And now we're treating it with this drug, and it was actually no attacks since we started with that. The second patient is something more special. It was a 69-year-old patient, and she started at 2006, at the age of 61, to have first attacks. In 2013, she represented in our department, and what was very important was the family history, that she has a niece who suffocated at the age of 19 due to a sudden throat swelling. She herself has only 1 to 4 times attacks a year, and sometimes with abdominal cramping. This is here the family history, and we found, oh, okay, I have a daughter has similar symptoms since adolescence, her son, when he got ACE inhibitors, this is here niece, and her brother actually had similar symptoms, like another brother. At the first, in 2014, we tried genetics and nothing was known, so we found no lab values were changed, and genetics factor 12 was the only known gene here, nothing found. But in that situation, we needed a management, and we did not have anything that was in label. We actually gave her icatibant, which was very, very efficient. In 2018, Konrad Borg described, together with Georg Dewald, a mutation in the plasminogen gene. It's now known as the K330E variant. It is very, very specific, and it is actually something that it's now known as the plasminogen gain-of-function mutation-related bradykinin-induced angioedema. The point with that mutation is actually that humans have the normal variant in humans is already a mutation compared to other species. So these patients actually have a more ancient variant of plasminogen, which might be the reason why it's more effective. So there has been a mutation during the human evolution that actually changed the plasminogen to become a little bit less active for whatever reason. Concerning the treatment, you may see here and notice that plasmine itself is not only able to elicit this factor 12 prekallikrein cycle, which then leads to bradykinin production, but also to release bradykinin itself from the high molecular weight kininogen. It's possible to treat it with tranexamic acid for long-term prophylaxis. With lanadelumab, it seems that it's not so efficient because of this bypassing. So just go for the summary. Always try antihistamines first, and even try to increase the dose up to 4 times. Then go for omalizumab. If it's not effective, consider bradykinin-induced angioedema. We are learning a lot of novel pathomechanisms, but it's actually still ongoing, and there are still a lot of mutations not known. Especially when you do exome sequences, you won't find them or identify them all. You might see them, but you don't know that they are. And we have a lot of novel drugs that are coming and will be very helpful in angioedema, but also allergic diseases. So here's some final view with our team, and I thank you for your attention.
Dear Dr. Rekka, thank you very much for this incisive and comprehensive description of this intriguing topic. I know we heard a lot today. It may take some time to digest and assimilate the knowledge, but it's a progressing science and understanding. Thank you very much for your presentation. I would like to see if anyone would like to ask Dr. Rekka. Yes, Dr. Yahya.
Thanks, Prof, for this excellent presentation. I want to ask you, in Egypt, to have low income, and we can't do all the investigations. Then my question is: C4 is enough for screening for hereditary angioedema? And if it is normal C4, can we exclude the hereditary angioedema type 1 and type 2? And I ask about the use of fresh frozen plasma if we have no one C1 inhibitor.
Yeah. So actually, if you don't have labs for C1 inhibitor, which would be more optimal, you can restrict it to the function of C1 inhibitor if you want to make the diagnosis. It is possible that you see C4 reduced in your patients, and then to say, okay, this is compatible with that. If you can exclude other diseases, I would say you can go for it. And if you don't have C1 inhibitor, fresh frozen plasma would be the best option. If you have a whole family, I was talking that attenuated androgens are typically not used. They are second line, but some people have only this chance. There are a lot of countries where all these very, very expensive drugs are not available, and they start with attenuated androgens. It's difficult in women and children, but in men it's possible. You don't need to have a high dose. People use something like danazol, 200 milligrams, or I also tried oxandrolone, which was, I think, 2 milligrams every second day, which was sufficient. But you have to just remember that this has its side effects, can cause thrombosis and liver adenoma. But if you have only C4 available, just go for the family history. And if you can dig deeper into the history of the patients, then you can do a lot of diagnosis based upon that. But at some point, it's very, very difficult. And as I said, I use theranostics, and treatment with omalizumab is already very expensive. I don't know how available this is. I think it's very expensive here in Germany, but there are other sources, especially when the biosimilars are coming up, then it might be possible to get omalizumab available at your side.
I mean, we do C4 as screening.
Yeah.
If it is normal, we exclude hereditary angioedema type 1 and type 2. If
it's to a certain
we
degree.
can go on. Is this true? If C4 is normal during the attack, we can exclude C1
Not completely. Not completely, but it gives you some information. If it's normal, then you can say, okay, might still be, but if it's reduced, then you can be sure that it's going into that direction. So it's not sufficient, but it is helpful. I would call it like this. Maybe you're 80% helpful. I have patients with hereditary angioedema. They have normal C4 levels, but most of them have clearly reduced C4 levels. So you might be able to make the diagnosis, but excluding it, needs a lot more effort. I would ask for the family history, and if you see, okay, the family history would fit, and the C4 inhibitor is normal, the C4 is normal, I would still say it's still possible, that it's hereditary angioedema. But if you have C4 normal and the family history is normal, you don't have abdominal cramping associated with attacks or a long-standing disease, then you can say, okay, this goes into the normal urticaria associated angioedema.
Thanks, sir.
Thank you. Any other question? Yes, Dr. Hussein.
Thank you, sir, for your elegant presentation. Just I have a question. What about the angiotensin receptor blockers? We know that we use these drugs in place of angiotensin S inhibitors because it not induced cough because of no increase of the bradykinins. If these drugs cause angioedema, what do you see? What is the pathogenesis of this disease?
Yeah, thank you for that question. I think it's still related to bradykinin, but I think when you have such a situation that patients have ACE inhibitors or angiotensin 1 receptor inhibitors, it might well be that they still have this normal urticaria-associated angioedema. And it's typically difficult to look at the drug if you won't have something like an immediate effect of introducing the drug on the angioedema, and you won't have an immediate effect upon discontinuing that drug, because you might have angioedema months after ACE inhibitors have been discontinued. This of course, it's not always the case, but it might be that you observe something like this. But in any case, we know that some patients react with these very complicated angioedema on angiotensin 1 receptor inhibitors. Pragmatically, when I have ACE inhibitor positive patients or patients reacted on that, I try to switch to angiotensin 1 inhibitors just to see whether they still have the problem of angioedema. But this is because both drugs somehow share some certain advantages, and it needs some more observation. So if you have such a situation that you have an ACE inhibitor caused angioedema, you might try to do that with AT1 receptor inhibitors, but just with some caution. Yeah, but it's possible to have it even in contrast or in the connection with AT1 receptor inhibitors. It's all this AEDI association. Even these niprelizine inhibitors or DPP4 inhibitors are known to be able to cause such a disease. I think it has maybe relationship to the genetic makeup of the patients. You won't find this coughing with ACE inhibitors in all patients. There are two genes, CPN1, XPNPEP, that are associated with higher risk for ACE inhibitor-induced angioedema without any other attacks. So you have to get oriented. But the mechanisms are not always so clear. This is the second message. So I cannot really say it's not related to bradykinin. I think many of these angioedema are related to bradykinin. Thank you.
Thank you very much, Dr. Recke. I think we are out of time. Thank you very much for your insight and for your excellent presentation. And we hope we can host you again in one of our thematic meetings of our School of Immunology. Thank you very much. It was a pleasure having you.
Bye. Thank you.
Okay. Our next speaker now is Professor Hanner Direskinelli. Dr. Hanner Direskinelli is a professor of rheumatology and is currently the chief of vasculitis clinic and division of rheumatology in the Department of Medicine in Marmara University School of Medicine, Istanbul, Turkey. Graduated from Istanbul University and had his training in St. Thomas Hospital in London, the Department of Oral Immunology in London. His current main research interests are genetics, immune mechanisms, infectious etiology, diagnosis with Doppler ultrasound, and management of Behçet disease, and genetics. Immune mechanisms, disease assessment with imaging, and management of Takayasu arthritis. He is a member of the OMIRACT large vessel vasculitis and Behçet study interest groups, and is part of the EULAR Task Force for Imaging in Large Vessel Vasculitis. He is also a member of ACR Global Engagement Committee, and he has more than 250 peer-reviewed articles in the medical literature. Welcome, Dr. Hanner Direskinelli. We are honored to have you with us today. Thank you for accepting to contribute to our annual meeting. This is our 14th meeting, and your presence is a great honor to us.
Thank you very much, Dr. Ragab. Thanks for the kind invitation. I am also very honored to talk in the 14th meeting of EGYSIR. Today, I'll talk about the cardiopulmonary manifestations of Behçet's disease. This is my outline. I'll talk about vascular Behçet's, cardiac involvement, pulmonary arterial disease, Hooch-Stevens syndrome, and finally the therapeutic approaches. Among my disclosures, apremilast study is important, but I will not mention it much as it's not studied in the cardiopulmonary Behçet's yet. I'll first start with a few words about the differences among the Behçet's manifestations around the world. Today, I'll mainly talk about the vascular disease, and as you can see, a vascular disease is seen mainly around the Mediterranean, in Turkey, Tunisia, Israel, as the most commonly seen countries. And in the IDA network Behçet's registry, which invite all colleagues interested in Behçet's to enter their patients, a multinational registry with over 1,000 patients. Among the predictors of major organ disease, including vascular disease, is first ethnicity and second gender. And gender is interesting because recently with our colleague Amr Savalha, we have studied a large cohort of Behçet's patients comparing the healthy controls in relation to HLA-B51 associated genetic risk. And it seems that both in Turkish and in other populations, HLA-B51 associated risk is mainly related to gender, to male gender, suggesting that B51, male gender and ethnicity are factors for more severe disease, and the vascular involvement I'll talk about. Now, I'll mainly focus on the vascular involvement in Behçet's, not mention about the other clinical aspects. As you know, Behçet's vascular disease is defined as a variable vessel vasculitis by Chapel Hill definition, which means is that no predominant type of vessel involved can affect vessels of any sizes, small, medium, and large, with arteries, veins, and capillaries. However, although the definition says no predominant, most of the time we see more commonly venous disease. Most common first event is usually a superficial thrombophlebitis or DVT. However, later on, other thrombotic events can happen. Arterial disease is seen as aneurysms or thrombosis in about 20% of the cases. Now, when we look at its epidemiology, as I said, there is quite different incidence in series from 15 to 50%. Of course, there is the importance of ethnical differences or the reference centers. However, imaging frequency and looking for vascular disease in asymptomatic patients is also important, which I'll come back to later on. In 10% of the cases, it can be the first major manifestation, and the patients can present without mucocutaneous disease. In our large Turkish multi-center series, we see the cardiac involvement about 3%, and the pulmonary aneurysms or thrombosis about 14%. Now, vascular involvement usually starts in the first decades of the disease. This is a series on the left from France, where you see that in the first 5 years, about 30% development, which gets less in the later on, with about 50% relapse rates. The interesting part is that in a study from Turkey, the first event that you can see here is usually a deep vein thrombosis, with other events less frequently seen. However, in the later events, it goes upwards. And for example, in the third event, a pulmonary artery involvement. In the fourth event, extrapulmonary aneurysms can be the major relapse vascular event. Now, if we start from the cardiac manifestations first, they are rare. And it's not clear whether they are really an increased risk compared to general population. The most serious one is intracardiac thrombosis. However, rare forms, coronary arteritis, coronary aneurysms, pericarditis, endocarditis, and endomyocarditis fibrosis are also reported. Among different cardiac manifestations, the most specific one, I think, is intracardiac thrombosis. These patients present with fever, hemoptysis, dyspnea, and cough, but do not have much heart failure or pulmonary hypertension and valve involvement. It's usually right-sided. It's the first manifestation in up to 50% and usually associated with pulmonary arterial disease. These intracardiac thrombotic events can disappear with high-dose glucocorticoids and prophylactically immunosuppressives. For this reason, unless there is a chronic thromboembolic pulmonary hypertension or valve disease developed, the need for urgent surgery is not clear, and most of the time, they disappear after treatment. Heart valve involvement is reported in sporadic cases. It's most commonly aorta, rarely the mitral and tricuspid valves, usually a diagnosis by screening. And in a series of aortic involvement, which had surgery in 19 cases, there was a high mortality, and there was a bad prognosis associated with high CRP with less use of immunosuppressives. So in patients with active disease, aortic or other mitral valve surgeries shouldn't be done. In this French series, about 10 years old, you see that there are reports of for about 40% pericarditis, which I think a bit too high, some endocardial involvement, and intracardiac thrombosis. Overall, the patients with cardiac involvement has a worse survival compared to other groups and also compared to deep vein central nervous system thrombotic events. Acute coronary syndrome is rarely reported and in fact is one of the most difficult ones that we are called upon. Typically, in a young age male patient, the cardiologists want to see a patient with usually aneurysms, sometimes with stenosis, in a routine or symptomatic intravascular coronary arteriographic investigation. A lot of the time, the smoking, hyperlipidemia, and hypertension are less seen in these cases. There are wall motion abnormalities, and usually they have interventions like PCI or CABG. In this review, or a systematic review, there is only really 50 cases reported with a very short follow-up. However, we should really be careful to try to separate from the standard early onset atherosclerotic cardiac disease from Behçet's, and unless other features of Behçet's are not present, by just looking at aneurysms or a bit high-grade stenosis, we shouldn't make a diagnosis of Behçet's in these patients. And finally, in this group, a big discussion is whether there is increased ischemic heart disease in Behçet's. Now, Behçet's is not like typical autoimmune diseases where the ischemic heart disease risk increases with age. And for a long time, we thought Behçet's like FMF, probably with not having too much chronic inflammation, do not cause ischemic heart disease. However, in this series from Israel, you can see that Behçet's, as well as male gender, is a risk for ischemic heart disease seen in these patients. However, this doesn't seem to be more than hypertension, hyperlipidemia, diabetes, and smoking as risk factors. And in another series from Korea on the right, you can see that, in fact, no increased risk is observed compared to controls. So other series should be presented, looking at compared to controls, whether there's an increased ischemic heart disease in Behçet's, but we still should be careful about the risk factors. What can be the differential diagnosis in vascular Behçet's? If there's deep vein thrombosis, we should try to separate from procoagulant intrinsic defects or anticardiolipin syndrome, for peripheral aneurysms from polyarteritis nodosa, in isolated aortitis from Takayasu or IgG4 related disease, and in coronary aneurysms or thrombosis, as I said, accelerated atherosclerosis is the most important differential one, but Takayasu and PAN can also cause coronary problems. Now, pulmonary involvement in Behçet's. This is in fact a more common and important problem compared to cardiac disease. It is 2 to 5% in large series with male dominance, onset usually 3-4 years after diagnosis. In the literature, it's usually pulmonary aneurysms with or without thrombosis, and about 1/3 of them had intracardiac thrombosis. Usually, pulmonary disease is associated with Budd-Chiari syndrome, vena cava inferior and superior disease, and cerebral vein thrombosis. Lately, thrombosis is much more reported, probably due to better CT imaging and early assessment. The relapses are about over 20% with a mortality 10 to 15% in 10 years. Now, I want to show you our cohort recently that we collected and in the journal now. Among our over 1,300 patients, we have 400 vascular Behçet's, and among them, 1/4 of them have pulmonary artery involvement. Most of them have pulmonary artery thrombosis with or without aneurysms. Sole aneurysms are not too much. Now, the interesting part about this series is that here you see that their mean ages is 42 with male dominance, with over 10 years of follow-up. DVT is 1/4. Some of them have chronic thromboembolic pulmonary hypertension with a low mortality. Now, about 1/3 of these patients are diagnosed asymptomatically. Of course, you will ask why you did CT angiography in these patients. The indication for imaging in these patients is whether they have a high CRP, high acute phase response unexplained by other causes, or as in the EULAR guidelines, if we plan for anticoagulation in patients with venous disease, to exclude aneurysms in pulmonary system to prevent bleeding. And when we compare these patients according to whether they are asymptomatic or not, the ones with asymptomatic disease has less disease duration, less main or lobar artery disease, and less pulmonary hypertension compared to symptomatic patients. And in this group, CRP was lower, but still high, about 4 times the normal, and relapse rate was also low, suggesting that we have an asymptomatic involvement, pulmonary disease in patients with Behçet's disease with probably a good prognosis if recognized early. However, in uncontrolled pulmonary disease, we can see cavitations or nodular disease. And in biopsies of these patients, there is acute hemorrhagic infarcts, vasculitis of medium-sized arteries around these infarcts, organizing pneumonia, or necrotizing glomerulonephrotic inflammation, suggesting some parenchymal disease also. Now, a few words about Hughes-Stevens syndrome. Hughes-Stevens syndrome is reported as a disease with pulmonary aneurysms plus a venous disease without any features of Behçet's. Although it is reported to be a separate disease, data coming from Middle East is suggesting now that it can be, in fact, in the spectrum of Behçet's. And in this series, comparing Behçet's pulmonary involvement with Hughes-Stevens from Turkey, it seems that they have a similar gender, age, and the symptoms are similar also. The most common symptoms are hemoptysis and cough in these patients with some dyspnea. Among the vascular involvement, most commonly pulmonary artery aneurysms are seen. However, in the Behçet's group, there is more pulmonary artery thrombosis, isolated one, compared to Hughes-Stevens, which seems to require pulmonary artery aneurysms. Interestingly, both these diseases have a close association with venous vascular disease, like lower extremity deep vein thrombosis, in both of them, inferior vena cava thrombosis, and also cardiac thrombosis, as previously told. So, at the end, probably Hughes-Stevens syndrome is possibly a vascular limited form of Behçet's, which we began to see more. And the therapeutic approach. Pulmonary arterial disease has an early mortality. This is similar to the cardiac disease. In these two series, on the left from France, compared to patients without arterial disease, patients with arterial disease have a 20-year mortality about 25%. And in compared to Hughes-Stevens syndrome, Behçet's disease patients also seem to have a bit increased mortality. In the treatment of this arterial disease, we should separate the venous disease from the peripheral arterial one. For the venous disease, we usually start with high-dose corticosteroids, at least 1 milligram per kilogram, if necessary, pulse treatments, and usually start with cyclophosphamide for 3 to 6 months. Anticoagulation is still debated. In the second line, anti-TNFs, adalimumab or infliximab is chosen, and in the third line, tocilizumab and or JAK inhibitors are tried. For the arterial disease, in addition to the first line approach, there is also possibility of, especially for peripheral aneurysms, endovascular surgery or aneurysmectomy. Again, anti-TNFs are the second line. Tocilizumab or JAK inhibitors are used in the third line. If you look at the infliximab data of a large group from Turkey, recently published, among the various vascular diseases, pulmonary arterial involvement has a good remission rate at 6 months, a bit less in the 12 months. Non-pulmonary arterial disease also responds about 60%. Venous thrombosis seem to have a bit better responses. However, if the patients have venous ulcers due to post-thrombotic syndrome complication, they don't seem to respond to biologic agents too much. There is one interesting study from Italy, published some years ago, comparing conventional DMARDs to adalimumab or adalimumab plus DMARD combination. Here you can see that the survival in patients without new events is worse in the conventional DMARDs. Nearly all patients relapse in about 80 months. However, adalimumab monotherapy, although seems to be effective in the beginning, seem to have a similar course. Only patients with combination therapy seems to be the best. And in these two groups, adalimumab or DMARDs, they published that adding coagulants doesn't seem to affect the relapse rate too much. In the pulmonary artery disease, so the main approach is glucocorticoids and conventional immunosuppressives in small aneurysms. In the large aneurysms or thrombosis, IV pulses or high-dose glucocorticoids, and cyclophosphamide or TNF inhibitors. In some centers, TNF inhibitors is beginning to be the first line, particularly infliximab. As I said, tocilizumab seemed to be effective in patients refractory to first-line treatments, and in refractory cases, embolization, lobectomy, pulmonary endarterectomy, and decortication can be considered. Here you see a recent series from China where tocilizumab is used in refractory cases every 4 weekly for 24 weeks with the continuation of immunosuppressives, and it is effective to decrease the steroid doses from 54 to 8 milligrams per day, the suppressing acute phase response, and suppressing the disease activity scores. And recently, we began to see the first data with JAK inhibitors. This is again a series of vascular Behçet's, mainly venous disease from China, where 17 patients followed approximately 11 months, and 88% complete response with good responses in acute phase response and disease activity scores, and a decrease of glucocorticoid dose is observed with baricitinib treatment. However, all of these are open label case series. Now, the most controversial issue in vascular Behçet's is whether to add anticoagulants or not. Now, compared to anticoagulants alone, immunosuppressives plus anticoagulants decrease the relapse rates in all series. However, when immunosuppressives alone is compared to the combination treatment, it seems that there is no decreased risk statistically available. However, most of the data comes from our own series in Turkey, where in fact there was a 23% decrease in the relapse rate, however, not reaching significance. And recently, we began to increase our patient analysis for this purpose, and especially look at our pulmonary involvement cases. Here you see the series that I presented before, and in the patients with thrombotic pulmonary disease, among the risk factors associated with relapses, there is age, increased age, symptom presence, pro-BNP, and pulmonary hypertension. However, patients without anticoagulant use are also prone to have an earlier relapses. So we think anticoagulant use should be a priority in patients with thrombotic pulmonary disease unless there are large pulmonary aneurysms. But most importantly, continuation of immunosuppression and/or anticoagulation is the most crucial to prevent relapses in vascular Behçets. In our Turkish series, most patients were not using any treatment before the first attack. After the first attack, about 90% use immunosuppressives and 60% use anticoagulation. But in about a year's time, the immunosuppression decreases to 50%, anticoagulation to 30%, and a new attack came in about 1/3 of the patients. Again, the treatments are increased. At the end, nearly all patients continue immunosuppression, and about half of them having anticoagulation. In order to prevent these second or third relapses, I think we should always continue immunosuppression at least for 5 years in all patients with vascular Behçets. If you look at the surgery, it's mainly in arterial disease, rare in venous one. It's usually a graft, ligation, or bypass surgery. And in pulmonary aneurysms refractory to medical management, endovascular embolization or lobectomy can be done. And in patients with end-stage pulmonary arterial hypertension, pulmonary endarterectomy is a choice. All of these operations are best to be done in patients under immunosuppressives and in remission. Here you see our publication from our group of first 9 patients 3 years ago who had pulmonary endarterectomy, and 8 of these patients are still alive, and they have a better functional class after the operation, and their pulmonary artery pressures also went down. And for non-pulmonary large arterial disease, there is also quite experience now. This is a series about 10 years old in 23 patients with only 1 mortality in 7 years. However, there is some patients with relapses or aneurysms, and especially with ligation procedures, there are some new claudication in some of these patients. Overall, we can say that mortality is especially high in young male patients with vascular Behçets. This is the French series, and here you can see that in the age groups 15 to 35, there is an increased risk of mortality in patients, especially young male patients. However, during a follow-up of approximately 30 years, it seems that all Behçet manifestations decrease with time. Usually, oral AFTs is the last one to continue over 50 years old. However, serious manifestations like ocular, vascular, usually subside in the long-term follow-up. So as a conclusion, I can say that cardiac events are rare in Behçets. Intracardiac thrombosis and coronary arteries can be seen. Whether there is increased ischemic heart disease is still not clear yet. Pulmonary arterial disease is increasingly recognized in the spectrum of vascular BD, especially with early CT imaging. All the aneurysms are the main concern. Currently, most pulmonary Behçets is observed to be thrombotic, and it can be asymptomatic with low acute phase responses. And whether there should be a routine screening for pulmonary disease is debatable, but we think it should be done at least in patients with a venous event. Conventional immunosuppressives, especially azathioprine, is combined with glucocorticoids as the first line for vascular involvement. Large aneurysms or main lobar pulmonary disease has worse prognosis and should be treated with high-dose glucocorticoids plus cyclophosphamide or anti-TNFs. Tocilizumab is the second line of agent. And pulmonary hypertension may require thrombectomy. In uncontrolled bleeding patients, there could be coil embolization, or in some cases, unfortunately, lobectomy may be needed. Thank you for listening, and I would like to thank my colleagues in Marmara University, the Turkish Vascular Behçets Group, and finally the Global Behçets Genetic Group led by Amr Savalha in Pittsburgh, which are producing very good data. Thank you.
Thank you, Professor De Lescanelli. Wonderful presentation. I will open the stage for questions. Okay, Dr. Mirvat.
Thank you, sir, for this incisive presentation. My question is regarding the use of JAK in refractory vascular Behçet. As we know, pathogenesis of Behçet may including some thrombophilic disorders like thrombin mutation, Leiden factor mutation. Is it safe or increasing the risk of thrombosis? Thank you.
The procoagulant mutations are studied in some series in Turkey, and we are now collecting a much larger one. It seems that especially procoagulant factor V Leiden and prothrombin mutations seem to be increased in Behçets, and maybe it's a good idea to look at these in all patients, whether they have a risk associated with this. And we think, especially in patients with prothrombotic risk factors, anticoagulation, effective anticoagulation becomes more important. There are now case series that we presented last week in Behçets Congress in Morocco that new oral anticoagulants can be a safe and effective option for this. For the moment, it doesn't seem especially necessary to have high level of oral anticoagulation, such as with warfarin, as in antiphospholipid syndrome, in Behçet's cases.
Thank you. Second question, yes.
Thank you,
Please
Professor.
Introduce yourself, please.
Sally Said, Assistant Professor of Internal Medicine at Azhar University. Thank you, Professor, for this illustrative and important lecture. I have a case of Behçet disease attend to me with polyserositis. I know that polyserositis is not one of the common manifestations of Behçet disease, but this patient came with a typical picture of Behçet disease and improved with immunosuppressant and anticoagulant and corticosteroid. Is it a common manifestation of Behçet disease to come with polyserositis? And is it management is suitable management for this case? And thank you.
Thank you for the interesting case. Yes, from time to time we see cases with pericarditis, pleuritis, not so much with peritonitis, in addition to typical features of Behçet. I'm sure you thought of it, but in Turkey, for these cases, we always think of a combination of Behçets and familial Mediterranean fever. And as the MEFE mutations are increased in Behçet's disease, we always look for these mutations, and especially if the patient is homozygous for M694 mutation or heterozygous, compound heterozygous for other disease-related mutations, we generally try to accept these cases as Behçet's plus an FMF case. But if not, if the patient is a pure polyserositis in your case, I think, of course, glucocorticoids with immunosuppressives will be the choice. But I would definitely continue colchicine. We sometimes stop it when there are other immunosuppressives. In these polyserositis cases, colchicine is a safe and effective option. And if the disease serositis becomes refractory, as in the autoinflammatory approach, IL-1 inhibitors, which I didn't mention much because there's not much data for vascular disease, but IL-1 inhibitors such as anakinra or canakinumab can be options for a case with polyserositis.
Thank you, Professor Driscanelli. Mustafa, can you please introduce yourself?
Thank you, Professor, for this elegant lecture. Mustafa Ali Saad, the lecturer of Internal Medicine and Rheumatology, Cairo University. I have two questions. The first, that you have mentioned that 10% of vascular case of Behçet may present by vascular involvement before fulfilling the criteria of Behçet's diagnosis. In such cases, do you think that starting with immunosuppressive therapy is based on sound grounds clinically, or in such cases, how can I manage those cases presenting with vascular involvement without fulfilling the whole picture of Behçet? This is the first one. The second one, regarding coronary involvement of Behçet, how to prove the causality between Behçet's and the coronary involvement versus atherosclerosis as a possible cause of this coronary involvement. In other words, how to manage coronary involvement by immunosuppressive therapy with certainty that this coronary involvement is due to Behçet, not due to atherosclerosis or premature atherosclerosis. And thank you.
Thank you for the important questions. Now, of course, when a patient comes with sole DVT, for example, it's not easy to make a Behçet's diagnosis without any accompanying feature. However, we should not forget that in a young male patient, usually below 30 years old, without any risk factor, without immobility, surgery, or procoagulant mutations, it is very rare to see a venous thrombotic event. So, in a young patient, maybe 25 years old, sometimes smoking, for this reason, suppressing their oral ulcers, we always think of Behçet's. Especially these patients are forwarded to us when they have a relapse under anticoagulation. We know that in Behçet's cases, if you only anticoagulate, you have up to 80% relapses. So especially if a patient had a relapse under anticoagulation, definitely we give immunosuppressives. But also, increasingly, in cases with DVT, without even any relapse in the first attack, in addition to anticoagulation, we add at least azathioprine to the standard treatment, maybe not very high dose of immunosuppressives. However, if the venous event is more serious, like a Budd-Chiari syndrome with DVT accompanying, which have a high risk of hepatic failure, we in fact are more aggressive, because in a 25-year-old Budd-Chiari case in Turkey with still normal hepatic function, but recognized with the collaterals, immunosuppressives can be life-saving. One issue here is that I didn't mention too much, but there are two tests coming now for better diagnosis. One is an increased pathergy reaction provided with pneumococcal vaccine stimulation. And the other one we are developing now is to look at the venous wall thickness that the patients, in these patients, if you have an experience in the department, especially radiologists, and you can contact us for this, that we are beginning a multinational study. We are looking with ultrasound the thickness of the venous walls in the common femoral vein arteries, veins, that it can be a helpful test in incomplete Behçet's. For this, your second question, again, in a younger patient, especially with less atherosclerotic risk factors, like a 30-year-old, again, maybe male, but not smoking, not very hyperlipidemia, not much calcification in the coronary arteries, but more aneurysmatic dilatation, we are more prone to give immunosuppression in addition to the standard approach. Especially if we find at the same time in these patients a history or a current a deep vein thrombosis, a venous event in addition to coronary aneurysms, definitely it supports Behçet's diagnosis.
Okay, thank you. Thank you.
Thank you very much, Professor Deriscanelli. We hope at some point or in the future circumstances will allow us to see you in person. Thank you very much for this enlightening lecture.
Thank you very much for kindly inviting me. I'd like to wish you a good Congress and hope to see you in the future.
Thank you very much. It was an honor having you. Our next speaker is Dr. Ahmed Faid. He is present in person here. Dr. Ahmed Faid is Associate Professor of Internal Medicine and Nephrology in the Faculty of Medicine, Cairo University. He is a nephrology consultant in his clinic and a consultant of clinical nephrology and renal transplantation at the International Medical Center in Cairo. He is also a consultant of clinical nephrology at the intensive care unit of Estetica Hospital, Cairo. Dr. Faid has extensive work with a special emphasis on the cryoglomerular vasculitis, and he has an access to one of the largest series of renal pathologies and data on cryoglomerular vasculitis and the kidney, some of which were presented and was among the first authors to report on the relapse after viral eradication in HCV. And he also has a special interest in the kidney and autoinflammatory disease, which is the topic of our today's presentation. And he has some publications and other work in press now. The lectern is yours for Dr. Faid. Go ahead, please.
Thanks, Professor Gafar, for this introduction, and thanks for this great invitation. Today, I will discuss the topics about the kidney involvement in the autoinflammatory disease. We will introduce the three important issues in my agenda, including the short introduction and the kidney involvement in autoinflammatory disease, which is the main topics, and also will discuss the other issue regarding the drug-induced nephrotoxicity in monogenic autoinflammatory disease. The term all of us know of the autoinflammatory disease is first raised in 1999 by Dr. Daniel Kashner, which is referred as a spontaneous episode of systemic inflammation in the absence of the high autoantibody titer and the antigenic specific T cells, and also the innate immune system is the main primary core or primary roles in the pathogenesis of autoinflammatory disease, and this is typically episode characterized by fever and systemic symptoms including rash, arthritis, serositis, lymphadenopathy, hepatosplenomegaly, IBD, CNS, and the renal involvement. And the most frequent monogenic autoinflammatory disease is the FMF, also the TRAP syndrome, and the other is the hyperimmunoglobulin D syndrome, mevalonate kinase deficiency, and the cryopyrin-associated periodic syndrome, which is one of the periodic syndrome. But this is the most common, but this is due to the next generation of sequencing and the biological technology, resulting into the identification of the new monogenic diseases, then the corresponding signal pathway that may help us in the targeted therapy. And the molecular mechanism underlying the autoinflammatory disease usually related to the inflammasome activation with overproduction of autoinflammatory cytokines, interleukin-1 beta, and also abnormal nuclear factor kappa beta signal, and also consecutive activations of the type 1 interferon axis, and inappropriate complement activation and the other cytokine signals, and all of this leads to the pro-inflammatory cytokine secretion, which is responsible for the most of the systemic feature and the persistence of the acute phase response. Kidney is considered as major target of the different inflammatory process, and the kidney damage is mediated through either amyloid pathway producing amyloidosis through the depositions of the acute phase reactant serum amyloid A protein that leads to the progressive glomerular and vascular damage and finally organ failure. And the other issue is the inflammasome activation and the interleukin-1 beta mediated vasculitis and vasculopathy. And still now, it is not clear about the kidney injury. It is a clinical feature or only the manifestation of the disease process. And this picture will summarize the kidney involvement. It may be glomerular involvement producing amyloidosis, vasculitis, glomerulonephritis, or crescentic or associated lupus nephritis, or renal vessel involvement including the different vessel Takayasu, polyarthritis nodosa, IgA, and amyloidosis, and also tubular interstitial affection producing Fanconi-like syndrome and granuloma. And there is another structural abnormality may be present, including the urethral and the pelvic calyceal system dilatation. We will depend on this picture in our lecture for the kidney involvement. First of all, we will discuss the glomerular involvement and mainly the renal amyloidosis in the autoinflammatory disease. Let you imagine the AA amyloid, which is secondary amyloid here, is common and it is considered as one of the severe complications, especially with the periodic syndrome. And during the systemic inflammation, the serum amyloid A protein, which is the beta protein that making the essence for the amyloidosis, it raised to up to 1,000-fold under the stimulation of interleukin-6, interleukin-1 beta, and tumor necrotic factor. And the prolonged inflammation causes the long-term elevation of this serum amyloid protein. Both increase the production and the susceptibility for the accumulation and deposition of serum amyloid protein, producing glomerular extracellular deposition of serum amyloid protein that deposited in the slit diaphragm, if mild, they produce low-grade proteinuria with the progression of the disease, nephrotic range proteinuria, and finally organ or end-stage kidney disease. And the clinical presentation, the most common is acute with nephrotic syndrome, but may be very insidious. But you must imagine that 5% of the case, the proteinuria is absent. And there is other maybe GIT disturbance like diarrhea, constipation, and malabsorption. And the hepatosplenomegaly is considered as the second most common manifestation. And when we compare to the AL amyloid, in AA amyloids, the congestive heart failure, peripheral neuropathy, macroglossia, and carpal tunnel syndrome are infrequent. And we must to do with this clinical suspicion, this corresponding laboratory criteria, including serum and urine for immunofixation, and also we must to do the genetic study to detect the AA systemic amyloid for detection of the mutation gene. And renal biopsy is considered as the corner of the stone with the deposition of the amyloid fiber and the characteristic positive Congo red stain with salmon color pink red, and also here the apple green pyrefringence under polarized microscope. The sensitivity is 98, but you imagine the absence of the Congo red stain don't exclude the amyloid. So immunofluorescence is very important to detect, to exclude the deposition of kappa and lambda, and the sensitivity only of the immunofluorescence is 65 to 85%, and the electron microscope finally detects the amyloid fibers that deposition here with the invasions of the basement membrane. When you go to the FMF, which is considered the first autoimmune inflammatory disorder, and it is the most common, which is due to the mutation of the MF gene, which encodes for the pyrine protein that leads to activation of pyrine inflammasome, resulting into activation of the caspase-1 and the release of interleukin-1 beta and interleukin-18, which is the major role here in the pathogenesis of FMA amyloidosis. And you imagine that amyloidosis may be even the first clinical presentation in some patient with FMF. And this is the phenotypes for the FMF with fever, serositis, and rash. The kidney involvement, as we mentioned before, proteinuria, nephrotic range proteinuria, renal insufficiency, and finally end-stage kidney disease. Effective treatment to colchicine must be started once the clinical diagnosis is established. Anti-TNF agent is the first biological agent that is used, and also the anti-interleukin 1 agent will be related in controlling proteinuria and improving kidney function, and also the tocilizumab interleukin 6 inhibitor shows significant decrease in the proteinuria. When go to the cryopyrin-associated periodic syndrome, which is inherited as an autosomal dominant, and the spectrum including the three main syndrome from mild to the severe, either familial cold autoinflammatory syndrome, which is mild, and also the Mickel-Well syndrome, also the nomad Senka syndrome. And this is caused by the mutation of the NLRP3 gene that encoding for the cryopyrin, and resulting into activation of the NLPR3 inflammasome and the caspase 3 with the overproduction of the interleukin 1 beta and the interleukin 8. All of this eventually resulting into switching of the inflammatory cascade in uncontrolled manner. And the three syndromes, this is the phenotypes for the familial cold autoinflammatory, which is characterized by mainly by cold-induced rash. The kidney involvement again is the lower extremity edema, massive proteinuria, renal insufficiency, and also hypertension. Anti-interleukin 1 is an effective treatment. And the second one, which is the Mickel-Well syndrome, which is characterized mainly by hearing loss and conjunctivitis, proteinuria, nephrotic syndrome, and renal insufficiency and end-stage kidney disease, and the effective treatment also is anti-interleukin 1. And the nomad or Senka syndrome, this is characterized mainly by CNS inflammation, kidney involvement again by proteinuria and impaired kidney function, and the effective treatment all of this as anti-interleukin 1. And when we go to the TRAPS syndrome, the TRAPS is caused by the autosomal dominant autoinflammatory disease caused by the mutation of the genes coding for the tumor necrotic factor receptor 1 mutation, which encoding for the that leads to misfolded receptor and accumulations in the endoplasmic reticulum that resulting into here enhancing the nuclear factor kappa beta, increasing the reactive oxygen species, and the impaired autophagy with finally overproduction of the cytokines. And the TRAPS is characterized mainly by migratory rash and the kidney involvement here, proteinuria with nephrotic syndrome, but there is a progressive renal failure that requiring transplantations or dialysis, and also there is a presentation of hypertension. And again, anti-interleukin 1 is the effective treatment. When to go to the mevalonate kinase hyperimmunoglobulin D periodic syndrome, which is an autosomal recessive autoimmune inflammatory disease caused by the mutations on the mevalonate kinase gene, and these mutations resulting into deficiency or reduced activity of the mevalonate kinase, and this leads to inhibits one of the RLHO pyrrolynation and finally activation of the pyrene inflammation and increase in the secretion of interleukin 1 beta. And this is characterized mainly by recurrent episode of fever and GIT manifestation with abdominal pain, vomiting, and diarrhea. And the kidney involvement here is nephrotic syndrome and end-stage kidney disease. And the effective treatment, anti-interleukin 1, anti-TNF, anti-interleukin 6, and kidney transplantation. But here you must imagine that in the AA amyloids in this mevalonate kinase deficiency, in 1/3 of the graft it usually recurrent if it is not controlled after transplantation. And to go to the DAT2, which is the deficiency of the adenosine deaminase, it is due to the autosomal recessive disorders caused by the gene mutation which encoding for the adenosine deaminase 2 protein. And this deficiency resulting into the switching of the macrophage differentiation to producing the M-type macrophage, which is the pro-inflammatory M-type that produce increase in the interleukin 1 beta 6 and the tumor necrotic factor 1. And this characterized by early onset of lacunar stroke and fever, and the kidney involvement mainly by nephrotic syndrome, effective treatment by the anti-interleukin 1. This is one of the syndrome called the Fixus syndrome with the vacuole E1 enzyme X-linked autoinflammatory somatic disorder. It is an adult onset that is refractory treatment disease caused by somatic mutation of one of the ubiquitin-1 gene, which affect mainly only the males. And this ubiquitin-1 gene encodes for the major E1 enzyme, which is responsible for all cellular function with ubiquitin signal. And this MET41 variant resulted into loss of the vacuolation and dysregulation of the innate immune system. Characterized by fever, neutrophilic dermatosis, vasculitis, thromboembolism, and macrocytic anemia, and bone marrow vacuole. Kidney involvement here with the progressive kidney disease and the high proteinuria, and it needs for the high dose of glucocorticoid and the anti-interleukin-1 therapy were effective. And this is the renal amyloidosis at the GN. When you go to the second, which is the renal vessel involvement, including the vasculitis, we will cause the renal vasculitis and autoinflammatory disease. Vasculitis is an inflammation of the blood vessel, which is considered one of the features of the autoinflammatory disease or closely associated with them. And the major dysregulated pathway in the different autoinflammatory disorder, it leads to the state of inflammation, endogenous inflammation, which either due to direct endothelial cytotoxicity by interleukin-1 beta and the type 1 interferon, or possibly an immunocomplex mediated mechanism. And the three vessels are affected, either the major vessel, which is the renal artery in that, like the Takayasu-like arthritis, or medium-sized artery like the polyarteritis nodosa, and also glomerular involvement with the IgA vasculitis. What is the clinical manifestation? First is the renovascular hypertension with gross or microscopic hematuria, proteinuria, and also oliguria or anuria, and the progressive renal insufficiency, and occasionally there may be the loin pain. When of this clinical manifestation, renal biopsy is considered as the cornerstone of diagnosis because we are dealing with the secondary vasculitis, and it may show, as seen here, fibrinoid necrosis with the perivascular infiltration of the mononuclear cell, neutrophil, and leukocytes, which is common, and also advanced aneurysm formation, thrombosis, and rupture of the vessel, and the crescent formation, and the focal mesangial glomerulonephritis, interstitial inflammation, and the tubulitis. All of these are seen in the renal biopsy with vasculitis. You remember the deaths as we previously mentioned in the renal amyloidosis. Vasculitis affecting the small and the medium-sized vessel artery is considered as the major feature of death and strongly associated with the classical polyarteritis nodosa, and the kidney involvement here by hematuria, proteinuria, renal insufficiency, renal artery aneurysm or stenosis, and finally infarction. And the effective treatment mainly here by the anti-tumor necrotic factor, and the bone marrow transplantation here is indicated in the patient with severe immunodeficiency, hematological impairment, and also the vascular phenotypes of that. FMF affected by the renal vasculitis in 2.7 to 7.2% of the cases, and the kidney involvement here by hematuria, proteinuria, and renal insufficiency, and the pathology mainly the IgA vasculitis, but maybe polyarteritis nodosa or Behçet's disease or granulomatous vasculitis. And the effective treatment mainly by corticosteroid and anti-proliferative cyclophosphamide, colchicine and azathioprine, and the plasma exchange is saved for the rapidly progressive glomerulonephritis with crescent. TRAPS also affected by renal vasculitis, producing massive proteinuria and the rapid deterioration of kidney function, mainly by the IgA-mediated vasculitis, and the corticosteroid, cyclosporin, and the anti-interleukin-1 are the effective treatment. And this nomad-Senka syndrome, there is only one case report that is published about the affections of female with crescentic glomerulonephritis, post-immune, with diffuse extracapillary necrosis without any amyloidosis, and this description extends the spectrum of this syndrome. And there is the Plough syndrome. It is another rare autosomal disease due to the mutation of the NO2 gene, which is the mutation of these genes leads into activations of the receptor interacting protein kinase 2 and downstream signal requiring nuclear factor kappa beta and the mitogen activated protein kinase, resulting into the production again of autoinflammatory antibodies. And Plough syndrome characterized by the triad of granulomatous polyarteritis, dermatitis, and uveitis. And the kidney involvement here is mainly hypertension and renal insufficiency, and the pathology is renal artery Takayasu-like vasculitis, and the effective treatment, it is resistant to the all currently available therapy in the literature. And there is another sting-associated vasculopathy syndrome, which is caused by the mutation of the genes that encoding for the sting protein that resulting into the consecutive overproduction of type 1 interferon, and characterized mainly by vasculopathy resulting into ulceration, necrosis, even amputation, and interstitial lung disease. And the kidney involvement are hematuria and proteinuria, and here is ANCA-associated vasculitis. Effective treatment by rituximab, mainly glucocorticoid and azathioprine. And the VIXAS, which previously mentioned, also half of the patients of this VIXAS syndrome is presented with vasculitis, but ANCA-associated vasculitis affecting the kidney was atypical. Only 2 cases with renal vasculitis has been reported, with kidney involvement with microscopic hematuria, and the kidney involvement ranging from GPA, post-immune, and renal peritubular capillaritis. And the effective treatment to both of these 2 cases are lack of prolonged response to the therapy. I want to go to the other issue for the renal involvement, which is the glomerular rather than the amyloidosis, which is the glomerulonephritis. There is a different type of glomerulonephritis have been observed in the FMF, mainly the focal glomerulonephritis, which is the most common. But the other, like the FSGS, IgA, and the minimally change may be affected. And when to compare to the AA amyloids, which is the commonest GN, these patients has the milder phenotype with proteinuria less than 3.5 gram, normal blood pressure, and the less aggressive course of kidney disease. Crescentic GN, it is also described in the case reports of the mevalonate kinase deficiency hyperimmunoglobulin periodic syndrome, and the kidney show the post-immune glomerulonephritis with diffuse interstitial fibrosis and also tubular atrophy with no amyloid deposition, and the effective treatment is anti-tumor necrotic factor. Lupus nephritis, there is one of the syndrome called the haploinsufficiency A20, which is caused by the loss of function mutation of one of the genes that encoding for the A20 protein. And this is important anti-inflammatory molecule. And some patients with this not only have the autoinflammatory disease, but they have the several autoinflammatory disease, which is the cross-link with the autoinflammatory disease, may have the systemic lupus, autoimmune hepatitis, and the psoriatic arthritis. And this is the phenotype, and the kidney also is the hematuria, proteinuria, and the relapsed nephrotic syndrome. Kidney involvement mainly by lupus nephritis 3 or lupus nephritis class 5, and the effective treatment, anti-tumor necrotic factor, yes, and the anti-interleukin 1 and the JAK inhibitor, tofacitinib, is very effective treatment. Another syndrome was affected by the lupus nephritis called the GRAG syndrome, which is affection by the mutation of the gene which encodes for the important signal, which is the cytosolic double-stranded RNA retinoic acid inducible gene 1. And this REG1 auto-inhibition resulting into consecutive activation of the type 1 interferon pathway. And they present mainly with the acute nephritis syndrome with rapidly progressive glomerulonephritis, nephrotic syndrome, and the AKI is commonly present with malignant hypertension, and the JAK inhibitor is the effective treatment. When to go to the one of the syndrome is COPA syndrome, which is caused by heterozygous mutation of a COPA gene, and this COPA gene is encoding for the alpha subunit of the Cotmar protein complex 1, which is required for the retrograde transport of sting protein from the Golgi apparatus to the endoplasmic reticulum, resulting into consecutive accumulation of this sting at the Golgi, resulting into enhanced interferon 1 signal and systemic inflammation. This syndrome mainly has the interstitial lung disease, arthritis, immune-related kidney involvement, and the acute kidney failure, hematuria, and the proteinuria. And the effective treatment till now, there is no available treatments in the literature, all are trial. When to go to the tubulo-interstitial affection, mainly the Fanconi syndrome and the granuloma. Renal granuloma, it is considered as uncommon and the atypical presentation of the Plough syndrome that we previously mentioned, and they reported in the literature. The renal involvement mainly by albuminuria and the microscopic hematuria with due to the granuloma formation and the tubulointerstitial nephritis, and again, Blau is resistant to the all currently available treatment. There is another syndrome which is presenting with the tubulointerstitial affection caused sideroblastic anemia with beta cell immunodeficiency periodic syndrome with developmental delay, which is due to the mutation, and the renal tubular dysfunction here is common and present with like Fanconi syndrome. Early onset of renal calculi with marked hypercalciuria finally ending to nephrocalcinosis, and the renal tubular Fanconi syndrome producing hypokalemia, hypophosphatemia, aminoaciduria, and the high urinary anion gap. And the effective treatment here was the red blood cell transfusion and the role of the IVIG as an immunomodulating agent, and the early bone marrow transplantation. And lastly, for the kidney involvement is the structure which is considered as the rare anomaly producing urethral and calcial dilatation called the H syndrome, which is characterized by symmetrical hyperpigmentations and hearing loss, characterized by urethric dilatation and distensions of the calyces, and there is no available treatment. This is the issue for the kidney involvement. When to go to the drug-induced nephrotoxicity, which is an important issue of monogenic autoinflammatory disorder, and the drug-induced nephrotoxicity, it may be induced by the three mechanisms. The first mechanism is the proximal tubular injury and the acute tubular necrosis and the interstitial nephritis, or maybe the tubular obstruction. The proximal tubular necrosis, the drug or their metabolites bind to the apical surface of the proximal tubule and is then transported from the apical to basolateral and then to the tubular lumen, and this mechanism is dose dependent. And the interstitial nephritis, mainly induced by the sum of the medication or their metabolite produce interstitial nephritis, and this is a dose-dependent process. And the tubular obstruction, the crystals or the cast containing medication and their metabolite may block the tubule, but this is dose-independent process. What is the risk factor for this nephrotoxicity? Mainly the pre-existing renal impairment and the dehydration, and also the concomitant use of nephrotoxic medication. Preventive measures, education for informing patient and the health care provider, and the precautions of taking many nephrotoxic medication together, regular checking for the renal function during medication therapy, and also ensure adequate hydration and avoid any crystalluria, and limit the exposure to the potentially nephrotoxic medication to avoid the prolonged use. So that patient with renal impairment, all of us know that they experience adverse event to the pharmacokinetic and the pharmacodynamics drug, and the clinician should know everything about the pharmacokinetics due to the different stage of the renal impairment and renal replacement therapy, and this to use this medication safely in this population. And this is the renal adjusted dose for different medications that we use in the autoinflammatory disorder. None said we must to closely monitor, avoid or reduce the dose as possible. Colchicine, it is not contraindicated, but it is recommended to be adjusted and closely monitor. With creatinine clearance, only use 0.3 milligram twice daily. Azathioprine, no dose adjustment is needed, but the following is recommended: with creatinine clearance from 10 to 50, administer 75% of normal dose, and less than 10, administer 50% of the normal dose. Anti-interleukin-1 inhibitor and Kinara, creatinine 3 to 50, normal, use the dose as a normal kidney function, less than 30, only 100 milligram on alternate day. Canakinumab, which is interleukin-1 beta inhibitor, there is no dose adjustment in patient with renal impairment. Infliximab, anti-tumor necrotic factor, with creatinine 30 to 50 as a normal function, but less than 30, only 100 milligram on alternate day. Etanercept and adalimumab, both, there is no dose adjustment in patient with renal impairment. And the tocilizumab, interleukin-1 6, creatinine clearance more than 30, no dose adjustment, and less than 30, it is not studied. And the tofacitinib with JAK inhibitor, more than 30, there is no dose adjustment, less than 30, not exceed 5 milligram per day, and the patient undergoing hemodialysis administers the dose after dialysis session on the dialysis day, and this is an important clinical text. And to summarize, and my take home message, the kidney represents an important target organ, and the injury is mediated by different pathological mechanisms, not only the amyloid related damage, but also non-amyloid related damage, like the NLRP3 inflammasome activation. And this is again the picture which we'll discuss in our lecture that involve the kidney involvement. And the severity of the renal impairment in some of the autoinflammatory disease should direct the physician to perform the diagnostic workup for nephropathy marker for early detections of the kidney impairment and use the overall better prognosis. And as we see in different autoinflammatory disease, targeting the interleukin-1 is a promising approach to manage the kidney disease, and hence providing and improving the long-term prognosis of autoinflammatory disorder. And again, don't forget, understanding the mechanism of the drug inducing nephrotoxicity and applying the preventive measure are critical for the safety manage on the monogenic autoinflammatory disease with renal involvement. And thank you.
Thank you, Dr. Faid, for we were pending behind you because of the sum of information. Thank you very much. Just one point that I wanted to address is the H syndrome. There are reports on the usefulness of using tocilizumab and even methotrexate.
Yes,
but,
yes.
The TNF blockers were not successful, and the interleukin-1 was not recommended in this entity.
The discussions for this treatment, especially for the H syndrome, for the using, but the long-term outcome, it is not studied in these cases that using the tocilizumab with the JAK2 inhibitor.
The reports were promising, however.
Yes.
Thank you very much. I open for questions. Yes, Dr. Abir, please present yourself to the audience.
Professor Abir Shahba, Tanta University, Rheumatology and Clinical Immunology Unit. Thanks, Doctor, for this lecture. I want to ask about the heterozygote FMF. We look to this patient as a very simple patient, may not give treatment, follow up for a long period, but I meet the patient presented by amyloidosis and renal failure, despite it is heterozygote compound. Is it possible, and what can we do? Patient already on dialysis, what can I do?
These patients with the familial Mediterranean fever, either heterozygous or the other issue, AA amyloids, it may be the first presenting symptoms. And the protection or the detections of the early detections for these AA amyloids by the diagnostic workup using the serum immunofixation and applying the anti-interleukin-1 and add the colchicine, as I mentioned in my lecture, is very important. But when you see in the late case, which is the progressive kidney disease with the depositions of these amyloid fibers in the extracellular glomerular and the closing the slit diaphragm, it will be fibrosed and interstitial fibrosed, and there is no rules for it except for the dialysis or the transplantation. And it may be the IA amyloids, it may be with the maybe the first presentation in the patients with the familial fever, as you say, Prof.
So thanks.
I wish to add that even after transplantation, one has to be very cautious to avoid further amyloid deposition in the transplanted kidney, and continuation of therapy is a must.
Yes, Dr. Gafar, and I say the AA amyloid, it may be recurrent in the graft, in the 1/3 of the graft, if it is not controlled. But after you transplant, you must to control the AA amyloids to avoid the further deposition of the amyloid fiber.
Yes, thank you. Another question, Dr. Nabil?
Thank you, Dr. Ahmed, for this elegant presentation. أنا محمد نبيل, Professor of Internal Medicine Rheumatology in بني سويف University. أنا أشكرك جدا إن أنت يعني ألقيت الضوء على entity مهمة جدا دلوقتي بقت موجودة, اللي هي المونوجينيك اوتو انفلاماتوري سيندرومز, مش بس اللي هم الكلاسيك الاف ام اف والترابس والسينكا والكولد بايرينوباثيز, لا كمان الفيكسس, ال 820 هابلو انسفشنسي, وكمان الجارد. بس انا سؤالي يعني زي ما حضرتك قلت بالنسبه مثلا حاجه زي ال 820 هابلو انسفشنسي, it shares common similarity in clinical picture with systemic lupus with بهشات.
Yes.
when to suspect this case, يعني انا ازعم ان كتير جدا من الحالات اللي احنا مشخصينها as Behçet's disease ممكن تكون A20 haploinsufficiency وتكون monogenic inflammatory. Is it مثلا the early onset of the disease?
هو الحاجتين دكتور محمد, the two issues, the first issue is the early onset of presentation and the rapid aggressions of the presentation with the kidney affection. It is with also the haploinsufficiency. Against the renal biopsy, we have the aggressive patient presenting with the progressive renal failure and also the rapidly progressive glomerulonephritis. And when you this is another systemic manifestation like the skin, as I mentioned. But when you take biopsy, you see also the lupus nephritis class 3. So that in these patients, the first two important from the nephrology perspective, the immunofluorescence is very important to show that the positions is very important, and also the electron microscope. If this condition and this suspected, the genetic study, it is the only clue for the diagnosis.
تمام. And after genetic study يا دكتور احمد, هل في مثلا يعني change of management plan مثلا, هل بتبقى مثلا more aggressive زي ما حضرتك قلت؟ هل
هي these patients management mainly as we aggressive rapidly progressive glomerulonephritis with the pulse steroids, and the additional issue with the using of the plasma exchange if there is a crescent that is present in the biopsy or the rapidly progressive glomerulonephritis. And they have this one case in our faculty which is presenting with the last 2 weeks, and is you managing by the plasma exchange due to the severe form of the pulmonary involvement and interstitial lung disease in this case.
Thank you, Dr.
Thanks.
Any other question? Okay, thank you very much, Professor Fahd.
Thanks.
Our next speaker will be Dr. Kurt de Vlam. However, our presentation will not be will be a recorded presentation as instructed or by Dr. Kurt de Vlam. Professor Kurt de Vlam is head of the Clinic of Rheumatology at the University Hospital of Leuven in Belgium, and he is the principal investigator and professor of rheumatology in the Skeletal Biology and Engineering Research Center of the Department of Development and Regeneration in Belgium. We had the pleasure of hosting Professor de Vlam in Cairo a couple of months ago during our co-meeting with the GRAPPA. We had him presenting a lot of topics. His main concern is the spondylitis group, and he has pioneer research in osteoarthritis. His topic today has got a very eye-catching title of Sense and Nonsense of Non-Surgical Interventions in Knee Osteoarthritis.
This review course about sense and nonsense of non-surgical interventions in knee osteoarthritis. Good afternoon, everyone, dear colleague. Here are my disclosures. This afternoon, we will deal with osteoarthritis. Osteoarthritis for a long time was considered as a disease of degrading cartilage. But more recently, increasing insights has shown that, in fact, cartilage is not the only organ or tissue involved, but in fact that osteoarthritis is a disease of the whole joint, that other structures of the joint, such as the synovial tissue, the capsule, the subchondral bone, are also involved, that there is neoangiogenesis and neurogenesis occurring, and that osteophytes might appear over time. This makes that future treatments will not only be restricted to try to improve or protect cartilage, but also deal with these other features of osteoarthritis. So different factors are available now to treat this osteoarthritis. You can consider that there is matrix degeneration, the matrix which is hypometabolic and is susceptible to catabolic events. There's also, you can treat this with anabolic and anti-catabolic projects to protect the joint. On the other hand, we see that there is also osteophyte formation, which signifies that there is a hypermetabolic pro-angiogenesis environment. And now different groups of factors has been identified to, on the one hand, treat with this hypometabolic state about the matrix degradation, and on the other hand, to deal with the hypermetabolic state with the pro-angiogenesis environment. So for the hypometabolic environment, you could use tropic factors like growth factors, TGF-beta, IGF-1, CTGF, or you can use catabolic, anti-catabolic factors, so products interfering with TIM, interfering with the MMPs. You could improve mesenchymal stem cell recruitment and differentiation. Several targets are available, and you can also use entheogenic modulators to have, for example, an influence on VEGF of angiopoietin 1. So there are different criteria available. There are many organizations dealing with recommendations about the treatment of hip and knee osteoarthritis. Here you see listed the most popular one. You will certainly recognize some of them, like the ACR recommendations, the ORC recommendations, the EULAR recommendations, and the NICE recommendations. And interestingly, if you look at the intended audience, you might perceive that, in fact, these different criteria have different audiences. And you see also that for some of the included populations, there might be differences. Some have recommendations for hip and knee, some have recommendations for all forms of osteoarthritis, or for different types of osteoarthritis, like inflammatory and metabolic arthritis. So what means that, in fact, different groups, different guidelines. Here you see an example of the ORC guidelines compared to the SKO guidelines. You will see that there are core treatments, and there is some resemblance between the core treatments, information about osteoarthritis and education are mandatory, and you see that in second line. Most of this criteria also advise exercise program. And from then on, the first line, the second line, the third line criteria might differ in some way. And one of the main differences, or the main causes of these differences of this recommendation, is partly explained by methodological difference, because it would be a bit strange that for the same disease, in fact, the general recommendations would be quite different. But it all depends on the, let's say, research methodology. And you see that, of course, some of these criteria include a degree of certainty, especially about the available evidence, and that might differ across different sets of recommendations. So here you see an overview of a recent meta-analysis about the different levels of treatment therapy in knee osteoarthritis, and you see the differences. You see that these recommendations originated in different groups. The most frequent, or those where you are most familiar with, are the ACR, the ORC, and the NICE and EULAR criteria. You see that some of the groups even doesn't give some advice about certain forms of treatment. And what is very striking is that in the top layer, you see there is a lot of agreement that exercises are mandatory, that education is an integral part of the approach of knee osteoarthritis, and that weight loss by all groups is also advocated. And from there on, you see that the level of evidence might be different, the level or the degree of recommendation might be different for the different approaches and for the different recommendations. And we will make a clear distinction between the pharmacological advice, injectable advice about the injectables, and nutraceutical advice. And here you see from the same recommendations that if we compare, for example, for the pharmacological recommendation, you see that hardly any drug is really advocated or recommended. Only the dark greens are fully recommended and have strong evidence. And what we see is that even between the to the 3 or 4 groups, there might be a different appreciation. For example, if you look at the NSAIDs, the non-selective or unspecified, or it's only ACR who finds that there is enough evidence, or full evidence for that, while the other groups have at least that there might be potential evidence. But more importantly is that, for example, that, and interestingly, is that topical, for example, topical NSAIDs are recommended by most of the group, but on the other hand, that non-specified opioids, including tramadol, including strong opioids, even transdermal opioids, are not at all recommended. You see from the more recent one or the more experimental one in the lower part, like anti-MGF, biphosphonate colchicine, even duloxetine or other strictly anti-inflammatory drugs are not recommended based on the lack of evidence to be efficient in this patient group. On the other hand, if we look at more local therapies, for example, for injections, and then here injections in the knee for knee osteoarthritis, you see that there seems to be some evidence for steroids, and we go more in detail about that. But let's say that about the other options, the recommendations are more weaker, and even there is even lesser evidence for a systematic, let's say, prescription of nutraceuticals. And here you see the whole list of available nutraceuticals. You're certainly familiar with glucosamine and chondroitin and the combination. There's some data about curcumin, there is some data about chondroitin, and there is some data about, for example, also vitamin D. And I will go a little at the end a bit in detail on some of this product. So let's start with the injectables. If you look at the market value of some of these injectables, then you are certain that they are very effective. But the main question is there's more belief than true science. And for example, if you look at the global market value for hyaluronic acids, which exceeds $10 billion in 2023, then you might think that this is very effective. Although, for example, we should divide it, but you see in the left upper panel that almost 2/5 of all hyaluronic acids are used for the treatment of osteoarthritis. If you look at the right side, you see even that this yearly value for the US market is increasing, and that also, let's say, the part of for the indication osteoarthritis is increasing over time. So let's look in the detail and let's look what the recommendations are. You will see that if you look for the recommendations here by the ORC, you will see that injectables, intra-articular corticosteroids, and intra-articular hyaluronic acid has a level 1B evidence, and it's recommended in certain conditions. And you look in detail, then it is especially in those patients who are more vulnerable with or without cardiovascular comorbidities, while, for example, patients with like topicals are not advised, and patients with like more systemic treatments like global NSAIDs are not advised. Some important issues to consider if you look at the results for injectables in the case of osteoarthritis is the time perspective. What time period, what time span do you want to evaluate? Do you look at the short term, this means 6 weeks? Do you look at the midterms, which is 3 months? Or do you look rather at the long term where you need at least a treatment for 6 months of a year? And you should look very carefully into the articles, into the data to understand what the effects in perspective of the time is of a certain product. There's also a difference between value and effect size. A p-value is a purely statistical evaluation, while effect size is a way of calculating the result and see in how much it contributes to the importance. I will highlight this in a number of examples. Thirdly, what is important, if you see a difference between the placebo, the control group, and your effective drug, what is the minimal clinical important difference? Because not all statistical differences have a important clinical impact. So it is very interesting, and it's needed to look at this MCID or SMD, and the SMD is the smallest detectable difference. So what kind of difference do you need to have a statistical significance? But the next step, which is more robust and more stringent, is the MCID. And of course, a big issue in this kind of therapies is that just injecting, just in even salt water, for example, might have a placebo effect. And that is an important issue to consider. So here you see what the smallest detectable difference is about a number of treatments we regularly use in patients with knee osteoarthritis. And let's start far right, where you look at just an intra-articular injections versus an oral placebo. You see that intra-articular injections has a superior effect to oral placebo, but that this difference doesn't reach the red dotted line, which is the MCID. You see the same for topical. You see, for example, here you see for the intra-articular hyaluronic acid with a lower molecular weight, lower than 1500, you see that all these treatments doesn't reach the MCID. If we go more far left, then we see that it starts to have or touching the bar of the MCID, some of them just by the variance, but let's say the 5 left more left have also a mean which is above the MCID, and this is for hyaluronic acid mid-weight and high weight. That's for post-ultrasound. That's for intra-articular PRP, and I come back to it, and it's for TENT. But you should not only look at the mean reaching or exceeding the MCID, but you should also look at the variance. And for example, the intra-articular PRP treatment reaches this MCID, but you see that it has a huge variance, and I will comment later on. And here you see also the effect sizes. You see the lowest orange line is a small effect size, less than 0.3, which means it has truly a weak effect. The MCID is a moderate effect, is between 0.3, 0.8, and then if it has a strong effect, you need to have an effect size above 0.8. And see, in fact, none of the means of whatever treatment reaches an effect size of 0.8, what means and such that there might be, in best cases, a moderate effect of your therapy, of all the available therapies now in osteoarthritis. So I will discuss with you injectables, the corticosteroids, hyaluronic acid, PRP, and Botox, and also some short words about the supplement, the nutraceuticals. So if you look at the aggregated data for corticosteroids, you see that there is only a short effect of steroids on both the VAS pain, and you look at the upper layer, the short-term effect is 6 weeks. We compared VAS pain with the WOMAC, and you see for both outcomes, you see a significant effect crossing the MCID. But if we look later on, between 6 and 3 months and or exceeding 3 months, you see that we lose this effect for steroids, both on the pain and on the WOMAC as a surrogate of function. You see that, in fact, this effect completely disappears over time. So this means that if you use steroids, then you aim to use it only for a short-term effect. So what about hyaluronic acid? Again, we compare pain with function. Mainly pain is measured by the VAS pain, function by the WOMAC or the COAS. Here they compared hyaluronic acid with placebo. This is a meta-analysis of all available studies who fulfilled the criteria. And what you see is that the effect of hyaluronic acid exceeds this MCID and favors hyaluronic acid at the short term here. And if you look at the function, you see that at short term, there seems to be a lesser effect on the function compared to the pain. But of course, this is evaluation on rather short term. If second important point by hyaluronic acid is that is in all the studies, there's a huge heterogeneity about type of hyaluronic acid. And what this slide shows here, that size does matter. If you compare the different, for example, the low molecular weight intra-articular hyaluronic acid with a high molecular weight, you see that there is a clear effect of the high molecular weight compared to the low molecular weight, and that the effect size of the low doesn't exceed the 0.5. And this is compared to intra-articular placebo. The definition of low weight and high weight molecular acid is mentioned below. So high weight means more than 6,000 kilodalton or higher. So apparently for hyaluronic acid, size matters a lot in the effect. A third option is platelet-rich plasma. Platelet-rich plasma is a technique based on blood collection, 30 to 60 milliliter of blood collected from the patient. We try to separate the platelets by centrifugation of the blood, and then the platelet-rich plasma is extracted, which usually means in a total of 2 to 6 milliliters of PRP, because this fraction in the centrifugation has a high concentration of different growth factors, including TGF-beta, for example. And what is this preparation is administered by injection in the joint. Most data is available now about injections in the knee. And in this cartoon, you see the sequence of events by a treatment of platelet-rich plaque. And what we see that at a long term, PRP seems to be superior for placebo. We see this for the WOMAC. You see that, in fact, if you use PRP, you aim rather a long-term effect than a short-term effect. You see in the upper part that, in fact, you see the effect increasing favoring PRP over time for the WOMAC, that you have a net bigger effect at 12 months than at 1 month. Somehow there is some effect also on the pain. Interestingly, here you see that the variance is much narrower than for the function. And again, also there seems to be some effect at the long term for the stiffness. And in global, for the function, you see that, in fact, the overall WOMAC is mainly driven by an improvement of function over time. If we look at the pain VAS, even we see a significantly improvement of the pain VAS at 1 month and at 6 months after PRP. If we compare PRP and hyaluronic acids, then we see that it outperforms steroids in pain and function at 6 months. And I stress this 6 months because, as mentioned, steroids have an effect on pain, but only at short term, at 6 weeks, but this pain is decreasing. This effect on pain is decreasing over time. So if you see at the effect differences in the left panel, you see in fact that the variance crosses the dotted line, which means that it is not significant. If you compare hyaluronic acid, you see that it separates, and PRP separates also from placebo at 6 months. And for function, you see a similar evolution. You see a similar effect on function by hyaluronic acid. And if we look at a larger perspective between 6 and 12 months and compare hyaluronic acid with PRP or steroids with PRP, we see that in fact the results increase. At the left side, you see comparison of hyaluronic acid and PRP. For the WOMAC, the overall WOMAC, the WOMAC pain, the WOMAC stiffness, the WOMAC function, and you see also the VAS pain. So the dotted line again is the MCID, and if you look at the overall WOMAC, we see that at month 6 and month 12, there is a significantly improved effect of the PRP compared to hyaluronic acid. For the pain, to some extent, you see the same, especially at month 12. For the stiffness, there is a slight improvement also at month 12. For the function, it's very clear that the main effect of the overall WOMAC is driven by the improvement over function in the case of PRP compared to the hyaluronic acid. And then if you compare just for the VAS pain, you see that there is a significantly but clinically less important improvement. If you use another tool like the COSE and you compare steroids with PRP, you see again that there is a significant improvement of the COSE pain and the COSE daily living, which is a surrogate for function at month 6. And here you see for the VAS, you see that on the direct effect on pain, none of the available treatment options has a real significant effect. So mainly the improvement is driven by a gain of function. So the last injectable option is Botox. You might be all familiar with Botox for other indications, clinical and more aesthetic indications. As Botulin A interferes with the nerve system and especially also with the nerve growth factor, it could have been an option as a potential treatment for knee osteoarthritis. If you look at an earlier study, you see that in a global population where they compared the pressure pain threshold, in fact, there was no significant difference. If we selected a more nociceptive population, again, you see that there was some significant effect on the tibialis anterior, but not on the knee. And the recent meta-analysis, which was present at the EGYSIR Congress in Vienna, showed that for none of the, not at short term, not at mid-term, not at long term, there was a superior effect of Botulin A compared to placebo of comparators. So that doesn't seem to be an option. Some words about nutraceuticals is that a lot of nutraceuticals and supplements are on the market. The problem mainly is that few of them have been tested in appropriate clinical settings with appropriate methodology and especially with a placebo-controlled arm. Although in general most of them are not tested, these authors found at least more than 70 clinical trials with more than 11,000 participants and 24 supplements who has been tested in an appropriate way. I also already introduced with effect size, and effect size over under 0.3 has a weak effect, an effect size between 0.3 0.8 has a moderate effect, which is mainly for injectables, and an effect size of 0.8 has a strong effect. And if we divide the whole group in this effect size group, we see that in the lower part, a number of potential supplements have a quite large effect size, and some of them might sound very familiar to you. It's like curcumin, different curcumin extracts, collagen hydrolysate, and boswellia. Others you might be familiar with, like glucosamine and chondroitin, which are in the upper part. You see that they have hardly any effect. And here in this meta-analysis, they looked again at the short-term effect, at the effect of different parameters, and in this case of pain at 3 months. And you see that the number of them crosses doesn't touch the dotted line at the left side and might have a significant effect on pain. Of course, what is the effect on function? And again, they listed all trials which evaluated function. And again, in the 3 different groups, weak effect, moderate effect, and strong effect. And we see again that a number of products seems to have a rather strong effect, including again curcumin and L-carnitine, for example, which will have also a clear effect on the pain. You see also boswellia and, for example, passion fruit peel extra. And again, you see that a number of them, which are regularly used, might have a short-term effect on the function. And here I want to just show you an example of a study we did ourselves with a curcumin longa preparate, and you see that curcumin in fact improves the knee pain at 3 months. We had 3 groups. It was a placebo-controlled study. 150 patients were included, and they were treated 90 days. And you see, if you look at the VAS of the knee pain, we see, in fact, that the active group already separates from the placebo group after 1 month, and that it separates further at 3 months, independent of the doses, because in this study, we used 2 dosages, high dose and low dose. If we look at the patient global assessment of disease activity, we see that in fact in the active group, where we combined the both dosages after 3 months, there was a better evaluation of the patient. And if we look at the absolute differences, we saw that the differences between start and 3 months, again, was bigger, significantly greater in the patient group with active product. And interestingly, we looked also at the cartilage catabolism, and you can do this in different ways. And a quite easy way is to look at cartilage-derived soluble biomarkers, and a number of them are available for testing in the blood serum of our patients. And we looked especially at soluble collagen type 2 degradation products. And we, for example, if we looked at the decrease over time, we see that in fact in the global group there was a decrease over time with, if we look at the absolute difference, which was significantly different after 3 months between the treated group and the placebo group, indicating that the cartilage degradation was slowed down in those patients who got a curcumin drug in this group. So there is still a large research agenda. Few things have been investigated about repeated injections. All the data I showed you was about a single injection. So what about repeated injections of corticosteroids, of hyaluronic acid, about PRP? A big issue with the PRP, although significant in many studies, is the high variability in preparation and sampling, which was highlighted in one of the earliest graphs I show, where although the mean reached the MCID, you see that there was a huge variance amongst the different studies. A third important point is defining the primary outcome. There is a whole debate ongoing in what should be the primary outcome. Should it be pain? Should it be function? Should it be structure? Actually, FDA and EMA only accept drugs or approved drugs that have a combined outcome like pain and structure. If you only fulfill once, you have little chance to be approved as a osteoarthritic drug. What about long-term trials? All the data I showed you were quite short-term, especially in the perspective of osteoarthritis, which is once it's started is kind of long life condition. And let's say the longest data available of the shown data is 1 year. There is some data about growth factors now, about 3 to 5 years, but there are still very few. And of course, it's very difficult to evaluate the effect on the long term, because then we should keep patients on placebo and regular evaluation for a very long time. So what about surrogate endpoints by, for example, the use of biomarkers and imaging markers to define the outcome and to evaluate if an active drug is superior to placebo? A point which has not yet been addressed, especially in this population, is the effect of phenotype and gender. We all know now that, for example, within the osteoarthritis phenotype, there are different subtypes. There is an obesity type, there is a metabolic type, there is a traumatic type. So, and depending on the insight, you might distinguish different phenotypes. And in the actual trials, this phenotype selection has not been addressed. A second important point is the gender-sex effect. We know all that osteoarthritis is more prevalent in female patients compared to male patients. And secondly, that especially as pain is one of the primary outcomes, that pain mechanism and pain perceptions by female and male patients is totally different. One of the latest points is, what about new targets? What about FGF18, this fibroblast growth factor 18, which has shown that there is structural effect, but no really effect on signs and symptoms? What about intervening in the Wnt cascade? And what about the GLP-1 agonism? There might be some data that, at least in vitro data, that GLP-1 agonism has a beneficial effect on the metabolism also of chondrocytes and might indirectly influence the evolution of the osteoarthritis. And finally, a point which is hardly addressed in any of the studies, what about early osteoarthritis? How should these injectables perform in patients with early osteoarthritis? And could early intervention prevent the evolution towards established arthritis, or even prevent, let's say, end-stage arthritis where like joint replacement is needed? So some take-home messages is that corticosteroids have an effect on pain and function, but only on the short term. Hyaluronic acid is superior on pain compared to placebo, but size matters. This is only true for the high molecular weight hyaluronic acid. PRP seems to be superior to placebo on pain and function. Hyaluronic acid and PRP are superior to steroids at 6 months for pain and function. PRP, in fact, is the only one who has a true long-term effect on function. And there might be emerging evidence that some of the supplements, and I showed you about curcumin preparation, might have a positive effect. Of course, the weaknesses of the shown studies is that it's all established osteoarthritis, calvin 2, 3, 4. They're very small. Most of them are quite small trials. even if we compare to other forms of arthritis, like nowadays spondyloarthritis trials, rheumatoid arthritis, where I have a couple of thousand patients included. And of course, since especially for the injectables, there is a high placebo effect in all this stuff. So I thank you for your attention and wish you a good afternoon.
I think we should all be thankful to Professor De Vlam for his wonderful presentation on this very ambiguous topic, still unresolved after all the sense and nonsense that we heard. This ends our first part of the review course. We'll be reconvening at after 1 hour and 5 minutes, exactly at 20 to 4.